Hello and welcome to this oncology news program titled A Tailored Approach, Evidence-Based Management of Advanced and Metastatic Non-Clear Cell Renal Cell Carcinoma. I'm Monty Powell, and I'm co-director of the Kidney Cancer Program at City of Hope, and I'm joined today by esteemed colleague, Dr. Wesley Yip. Welcome, Wes.
Hi everyone, I'm Wesley Yip, a urologic oncologist, also at City of Hope, who works very closely with Monty Powell. Very happy to be here as part of this discussion today.
Now today we're actually going to be discussing the best approaches to individualized management of patients with advanced or metastatic non-clear cell renal cell carcinoma. But really briefly to start, Wesley, can you just give us a brief overview of non-clear cell disease?
Yeah, sure. So of all primary renal neoplasms, the tumors that we see on kidneys, RCC makes up about 85% of them. That can be a little bit lower number in smaller masses and larger and bigger ones, but across all comers, about 85%. Now, of RCCs, about 25% of those are non-clear cell RCCs. There's a lot of different subtypes within this group, so it's very heterogeneous, and there's variable prognosis and overall survival based on the different types of groups. Talk a little bit more about it, but there's a difference in 5-year overall survival outcomes per group. For papillary, for example, it's typically about 90%, but then for some less common variants like collecting duct, it's more like 40%. So if diagnosed early, surgical resection can be curative, but even in earlier stages, recurrences can occur in these subtypes. Overall, about 15% of patients with RCC present with metastatic disease, and it's these patients, once metastatic, that have much lower 5-year survival rates. So the non-clear cell RCC is a diverse subset. It's much less common than clear cell RCC. And within it, there's papillary RCC is probably the most common. So it used to be split up into type 1 and type 2, but now there's just type 1 papillary RCC and papillary adenoma. So those definitions kind of changed over time. There's other variants like chromophobe RCC, and then even some other ones that are hereditary forms. Then also of note, it's not technically a subtype of non-clear cell RCC, but there's sarcomatoid and rhabdoid differentiation that you can also see, and that can coexist in other RCC histologies. This is something that might affect prognosis and management and how we treat the disease. So within non-clear cell RCC, there's certain subtypes that have different clinical courses and responses to therapy. Type 1 papillary RCC historically had a much more indolent course with better clinical outcomes compared to those with type 2 disease, which was historically much more aggressive. Then there's also the chromophobe subtype, but this usually follows a more indolent course, and historically this has been resistant to immunotherapy options. Overall, non-clear cell RCCs are a pretty diverse group of histologies. They're less commonly seen than clear cell RCCs, so about 25% of RCCs in renal masses. Historically, non-clear cell RCCs have been treated by default based on clinical trial results showing efficacy in patients with clear cell RCC. But now there's a lot of new studies and clinical trials that have evaluated patients with non-clear cell RCC specifically. Some of these have shown promising results, especially in papillary RCC, and there's some preliminary data in chromophobe subtypes. So I'd like to talk a little bit more about the management of this in more detail. Monty, how do you approach first-line management of non-clear cell metastatic RCC based on tumor and patient-specific factors?
That's a great question. I have to tell you, Wesley, that was a terrific overview. I think that the clinical presentation of non-clear cell RCC can dictate the treatment approach, and it really does require a lot of very close collaboration between, for instance, yourself and myself, straddling the line between different specialties like urology and medical oncology. I think if a patient really has a low tumor burden, if there's asymptomatic presentations, you can consider surveillance as a strategy. And I do think that it's really critical that we discuss the role of local therapy in patients with non-clear cell RCC, depending on their initial presentation, using things like radiation, surgical resection of solitary mets. It's really, though, in patients that have bulky tumor burden, symptomatic disease, and mets outside of the CNS, where we might consider the role of cytoreductive nephrectomy, for instance. Type 2 papillary and medullary subtypes of non-clear cell disease tend to be really aggressive, and these are the subtypes where you might want to jump straight to systemic treatment up front. Now, especially in earlier stage disease, but even more in advanced, surgery really remains a mainstay of management. Wesley, can you maybe explain how you approach surgical management in patients with advanced or metastatic non-clear cell RCC?
Yeah, sure. I'd be happy to touch on that a little bit. So Patients even with stage 4 disease can benefit from surgery, but it's very patient dependent in certain factors that we have to consider. First of all, are they truly metastatic or not? There are some patients who have lymph node involvement on CT, for example, but this can be hyperplastic and it's not always actually involved by tumor, so minimal regional adenopathy really does not preclude surgery. But then even in patients who have biopsy-proven metastatic disease, as you mentioned, there is a role of surgery even in these patients depending on the mass. So patients who have the majority of their disease confined within the kidney, if they're symptomatic from this in terms of pain or bleeding, these can be reasons why we might consider cytoreductive nephrectomy in these patients. And then also depends on where the metastases are. So there's certain prognostic factors that are better. Patients with only lung mets, some with good other prognostic features, and especially the performance status, because these patients have to be able to tolerate surgery. So it's something that varies patient to patient, but we look at them closely to see whether or not they'll benefit from surgery.
Now, I've got to ask you, when would you consult radiation oncology?
So, here it's a pretty multidisciplinary discussion. A lot of times we consider this when the primary tumor is resectable, but maybe they have an oligometastatic site. So they might have just one lung lesion or somewhere else. So sometimes we'll consider nephrectomy with surgical metastasectomy, but we can also consider radiation therapy, so SBRT or other ablative techniques to some of these other sites. Usually there's certain oligometastatic sites that are more amenable to this approach. Lung especially, can be the bone, but even the brain too. So these are the kind of things we talk about at Tumor Board together, where we all put together a plan that's multidisciplinary and everyone's on the same page for this.
Yeah, that makes a lot of sense. I love tumor boards for sort of arbitrating these decisions. I really find that having a healthy discussion around surgery versus a radiation-based approach is really critical. Is there any role, would you say, for combining systemic therapy and radiation or surgery, maybe in the context of oligoprogressive disease? And do you find that the nature of the systemic therapy matters in terms of when we're deciding to do, for instance, a bigger surgery like cytoreductive nephrectomy?
So definitely, and I think this is really where that multidisciplinary discussion comes in. It's important of how we time these different things and what we're using. So if there's going to be radiation, we have to figure out where that is in terms of our surgical field, make sure we're not overlapping things, and making sure that one will not obviate the other one. In terms of the systemic therapy options, this is really important because there's so many different systemic therapies now. Huge difference between VEGF-targeted therapies versus immune checkpoint inhibitors when combined with cytoreductive nephrectomy. It's really important to have a close relationship with the medical oncologist about timing of this, because there's a lot of different outcomes in terms of surgical complication rates based on patients who have received VEGF-targeted therapies, TKIs, versus immune checkpoint inhibitors. There's also a really big difference in the duration of action of these medications, so how long the TKIs last for, if they're fast on, fast off, if they're slow on, slow off. That affects the timing of surgery. So there are several series out there that have looked at surgical outcomes for cytoreductive nephrectomy after systemic therapy. Typically, patients after TKI have more complication rates. After immune checkpoint inhibitors, higher than normal nephrectomy cases, but not necessarily higher than cytoreductive nephrectomy cases. So the surgeries can be more complicated, they're more challenging, they're usually referred to academic or specialized centers with experience in this, but they're definitely feasible. They just have to be done with timing that's set up with the medical oncologist closely. Now, in terms of whether or not it'd be surgery first or systemic therapy first, vice versa, depends on the patient factors, the tumor burden, how they're feeling, whether or not they can tolerate surgery, whether or not it's resectable or not. So there are times where patients get systemic therapy up front, surgery is delayed, and then later on we consider surgery. So there are patients who did quite well on systemic therapy. Maybe the rest of their tumor burden elsewhere has shrunk down, or they don't have any evidence of disease elsewhere, and then it's unclear how long we would keep them on systemic therapy without treatment to the primary. So sometimes we might consider cytoreductive nephrectomy in these patients. It can also offer them a window to not be on systemic therapy afterwards and just surveillance.
Yeah, I think that's a great point. I mean, I definitely think that in that scenario, right, where you have a patient who's responded exceptionally well at all their systemic disease sites, but still has that big, bulky primary, it makes a lot of sense to at least consider taking them to the OR. So it's a great point, Wes.
I definitely think so. And so there are a ton of systemic therapies out there now, and there's a lot of really exciting advances, especially recently in the last few years. So Monty, I was hoping you could tell us about what's included in the NCCN guidelines, and what do they tell us about the role of systemic therapy in non-clear cell metastatic RCC? Especially with cabozantinib, which I know you have a lot of experience in. Is this the first-line standard of care across all patients with non-clear cell metastatic RCC?
Yeah, it's a great question. You know, when you look at the NCCN guidelines, you can see that for non-clear cell disease, cabozantinib is the preferred approach. We do have a multitude of other recommended regimens. That includes lenvatinib and everolimus. You can see nivolumab, cabo-nivo, pembrolizumab, and sunitinib as all being options here. I will say that systemic therapy is something that we would recommend for the vast majority of patients with this disease type. I would say that cytoreductive nephrectomy is certainly a consideration, but the priority should always be thinking of what treatment that we're going to render to a patient in most circumstances. Now, you know, I will say that one of the biggest challenges is that there's not really a well-defined standard of care for patients with non-clear cell renal cell carcinoma. You know, as we mentioned, the preferred treatment for non-clear cell RCC is really inclusion in a clinical trial or cabozantinib. But there's a multitude of other regimens that we can refer, and the latest NCCN guidelines do not include TKI-IO combinations such as lenvatinib and pembrolizumab, which actually has some recent clinical trial data associated with it. So that's something to bear in mind. So Wes, I've devoted a big chunk of my career to this trial, which is known as the PAPMET study or SWOG 1500. And this trial compared sunitinib, which is a control arm, to cabozantinib, crizotinib, and savolitinib. And the whole premise of this study is that we think that papillary RCC is driven by MET biology, right? So in this trial, we suspected that one of those three MET inhibitors, cabo, savolitinib, or crizotinib, would potentially win out. In point of fact, crizotinib and savolitinib arms, those were stopped pretty early in light of futility. Cabozantinib did show superiority to sunitinib with a PFS advantage of 9 months versus 5.6 months. There was no overall survival advantage there. So I think the big question that sort of arises on my mind is whether or not cabozantinib really reflects the standard of care. You know, and moving on from this study, I started getting involved in some trials looking at cabozantinib with immunotherapy. So on the left is a study that I ran with Neeraj Agarwal from the Huntsman, looking at cabozantinib with atezolizumab. Now, atezolizumab is a PD-L1 inhibitor, maybe not our best out of the checkpoint inhibitors in general, but having said that, we saw a pretty healthy response rate overall in patients with non-clear cell kidney cancer, including chromophobe and papillary and others. And within papillary specifically, since we're on that subject, response rate was 47%. And I was really reassured when we got data from Kelly Fitzgerald and the group at Sloan Kettering, this was recently published in European Urology, showing that the response rate for cabo-nivo, very similar regimen, in papillary RCC was 47% as well. So you really do have two data sets producing relatively similar results, and that's always reassuring. But there's more beyond cabozantinib and its cognate partners with immunotherapy. You know, I think that we can look at bevacizumab with atezolizumab. The response rate with atezo, ostensibly a weaker regimen, was 25%. And with lenvatinib and pembrolizumab, this is one study I would like to hone in on a little bit. We see, as you can tell from the waterfall plot, many more patients, 93 in the context of this study, and a response rate that's kind of the high watermark so far at 54%. Is it easy to draw a distinction between 47% with cabo-nivo or cabo-atezo and 54% with len-pembro? Probably not, but I think there's some strength in the study in the numbers with 93 patients, so that's certainly very compelling. Now, if we kind of move on from this study, I wanted to highlight a couple of approaches that I think are quite unique. So we've talked about MET-Wes, and you know, one of the things that's kind of ironic is that when we were designing PAP-MET, we had conversations around dialing back and just focusing on MET-altered people in the study. But having said that, we ultimately focused across the entire swath of patients with papillary RCC. The development strategy for this drug savolitinib has been different. Now with savolitinib, they've really focused on those individuals who have MET-altered disease. So in a phase 2 study, you see one principle shine through, which is that if savolitinib is going to work, it's going to work in patients who actually have MET-driven disease. So this would be changes in copy number, changes, for instance, in MET expression and mutation. So that's really where we see that take impact. And then on the right, you see the combination of savolitinib with durvalumab, which is PD-1 inhibitor. And in that particular context, what we see is a response rate of 53%. So this is kind of closing in on the numbers that you see in the context of lenvatinib and pembrolizumab, but this sort of dials it specifically into a MET-altered population. So lots of interesting data in this particular regard.
Thanks so much, Monty, for that overview of all the studies that have happened so far into this space. And clearly, inclusion in clinical trials is a really big part of the management of non-clear cell metastatic RCC. So for a more general audience, other people who might be watching this are community oncologists, what are some of the ongoing trials that community oncologists should know about, and which patients are the best candidates compared with implementing one of the approved systemic therapy options? So who should they be referring out to bigger centers that might be offering these kind of trials?
Yeah, that's a great question, Wes. I would say everybody with non-clear cell renal cell carcinoma probably deserves a visit to a tertiary center with some expertise in this disease type. It's incredibly rare. The treatment strategies aren't necessarily obvious, and there's so much room for development in this field through clinical trials. And fortunately, we're at a time when we have many available. I do remember when there was a bit of a dearth of these studies, but now really across the country and around the world, frankly, I bet it's possible to get your patient to a center where there's a study available for their specific type of non-clear cell RCC in many cases. If we look to the PAPMET-2 clinical trial, this is a study that was really generated by virtue of the PAPMET trial. We saw the data for cabozantinib and thought, well, maybe we can benefit patients further by adding atezolizumab. We know the data for cabo and atezo that I'd highlighted previously, but we do need randomization, right? I mean, randomization is one of the hallmarks of current care in oncology. So this is a randomized phase 2 study. Will this be practice changing? I don't know, only because randomized phase 2 studies have really never sort of made the mark with regulatory approval, but an important study nonetheless. I'm a little skeptical of the PAXI-PEM study, which uses axitinib as a base in patients with papillary RCC. I really haven't seen very compelling data for axitinib in this context, so it'll be interesting to see whether or not axi plus or minus pembro, kind of like the upfront approach we've taken in Keynote 426, if that's going to play a role here. But nonetheless, I think that it's a reasonable trial design. I'm very, very excited about two trials, Stellar 304 and Sumanta, because these could finally, Wes, move the mark for patients with metastatic non-clear cell RCC and really pave the way for some drug approvals. We'll talk about in just a little bit the fact that, there's really no established standard. It makes it really hard for payers and other agencies to define current practice. Well, in Stellar 304, this is a phase 3 design. So it looks at zanzalintinib, which is a novel VEGF MET inhibitor. Think cabozantinib, but with a shorter half-life. It has some other unique properties. Zanzalintinib combined with nivolumab is being compared to sunitinib in this randomized phase 3 study. And this trial doesn't just accept patients with papillary disease. It also takes patients with unclassified and translocation histologies. And this could lead to registration. Likewise, the Sumanta trial looks at savolitinib and durvalumab in combination. And this approach is being compared to sunitinib versus durvalumab as single-agent control arms here. And again, because they're taking patients who are MET-altered, because they're really sort of teasing out the biology, it's a very honed approach. I think this stands a chance to really render some benefit. Now, kind of beyond these trials here, which you've outlined, I think, again, we can reflect on the fact of whether or not there really is an appropriate control arm right now, if there's a current standard. I'm going to argue no. I mean, I'll tell you that, this was just last year. I tried to get cabozantinib for a patient, and this is 2 years after the publication of the PAPMET clinical trial. So this is a little bit frustrating to me. And the payer shot back saying, well, did you try sunitinib first, right? This is a preferred medication. So it was really quite frustrating. And it sort of articulates, I think, some of the challenges that we face in getting a quote-unquote standard of care out to our patients. Now, I will say that I've focused a lot so far, Wes, in responding to your question on papillary RCC, but I will say that there's a glimmer of hope here for chromophobe RCC. Now, chromophobe is just 5% of all cases of RCC. It's a histology that really needs more attention. But what we're seeing is that there's some great data for lenvatinib-based regimens. So Lenvatinib with everolimus, for instance, has a response rate of 44% associated with it. Lenvatinib with pembrolizumab, again, that large data set from Keynote B61, this trial actually has a response rate of 35% in papillary patients. And, we might look at these numbers and say, well, 9 patients with Len-Ev, there are 29 patients with Len-Pembro, what's the real utility there? This might be the best that we have for now. So right now, if I see a patient with chromophobe type disease, I'm really suggesting that they get on some lenvatinib-based therapy, really as suggested by these single-arm studies. This Keynote B61 study, it's important to highlight, Wes, that this is the largest trial to date in non-clear cell kidney cancer with a PFS of 17.9 months across the board. It did have a whole host of different tumor types, so if you really sort of claw into the data, there's great data for papillary with 93 patients out of the 158 enrolled. But for certain subtypes like translocation, for instance, we only have 6 patients. So I don't want to really make heads or tails about what's best for those patients. For those patients, keep in mind trials like Stellar 304, which do accept translocation RCC patients. So, that's my suggestion. And I do think that there's still some utility in retrospective experiences. This year at ASCO, we saw some retrospective data for chromophobe RCC. I wish we could really sort of get granular and say, well, this TKI IO is better than that TKI IO and so on. But the general premise is that the combination of targeted therapy and immunotherapy seems to be best in this disease type. That was sort of the fundamental result in my mind.
Wow, that was a really great review of the current data, Monty. Extremely high yield. We've also been kind of at a higher level in this. And so I really want to know from a more individualized standpoint, really the patients themselves, how do you incorporate this non-clear cell RCC data, specific data, combined with the latest NCCN recommendations in your practice? What are the disease and patient-specific factors that you're considering when developing a treatment regimen for patients with non-clear cell metastatic RCC?
That's really a phenomenal question. I think that kinetics is really key. It's tough, Wes, because I think that you're really sort of the gatekeeper for many of these patients. They'll see you first when they're diagnosed. And I think one of the challenges, and I sympathize with this, is that when you see a patient who has metastatic disease from the outset, it's hard when you don't know how long it's been there, right? When they have large pulmonary nodules, a big primary tumor, we can't tell unless we have the benefit of prior scans if it's been there for a year, 3 months, or 6 months. And so I think sometimes we're left guessing in that regard regarding how long this disease has been around, whether or not it's rapidly growing, or whether or not you have time for a clinical trial to treat. I would really look hard if I were giving advice to the day-to-day practitioner to see whether or not you can identify any previous scans. If you can define those tumor kinetics, and if they've got an opportunity to go get a second opinion and get onto a clinical trial, by all means, I recommend that you do that. If there's other things that indicate a rapid tempo of disease, rapid weight loss, lots of symptoms, etc., by all means, feel free to start therapy right then and there, maybe with lenvatinib pembrolizumab, maybe with cabozantinib nivolumab, depending on the nuanced circumstances. But I would say that those are sorts of the drivers as disease kinetics. How about you, Wes? What are some of your drivers in terms of seeing these patients up front, maybe in terms of the decision around cytoreductive nephrectomy?
Right, so it definitely is, again, the patient themselves, what the primary tumor burden is versus at other sites. Are they symptomatic from that primary tumor? Is there pain? Is there bleeding? Is most of it there versus elsewhere? How fit they are, and whether or not they can tolerate surgery. Would they benefit from surgery or not? There are definitely some patients with really large tumors. They're very ill from this large tumor, and they get much better afterwards. But still making sure that they're supported and they're going to be able to tolerate surgery and actually benefit from it.
Yeah, really, really well said.
And now you've given us a really great overview of the response rates of these different regimens, how they do in different histologies. But to the patients themselves, what about adverse effects? What are you most concerned about with these systemic therapies that you're frequently using in patients with non-clear cell metastatic RCC?
The truth of the matter is I don't think that the side effect profile is that different for my patients with clear cell RCC versus non-clear cell RCC. You would imagine perhaps that the patients with non-clear cell RCC tend to be younger. You have diseases like medullary RCC, which really sort of hits patients, unfortunately, in their 20s and 30s. And that's true, frankly, for many of the non-clear cell histologies, not quite as young, but young no less. I haven't found that that necessarily gives them a higher threshold for accepting toxicity. I think toxicity can just be as problematic. I do find myself trying to maintain dose intensity more, really because in my non-clear cell patients, I know that maybe they don't have the benefit down the line of getting to third and fourth and fifth line treatment. We only have a couple of shots on goal here. And so I will say that it's really important that, if possible, we hang on to dose. And the ways that we do that are through vigilant dose reductions, really carefully discussing with patients whether or not there's a true indication for dose reduction or if their symptoms can be mitigated by using palliative care methods. I think the other thing that I like to employ is drug holidays, giving patients gaps in terms of their sequence of therapies I find to be really, really helpful. So those are all the things that sort of factor into my equation when I'm considering whether or not to jump into treatment. I will say that, collaboration is key, and we're so blessed to be at a place like City of Hope, where I think we've got phenomenal collaborators, folks in rheumatology, palliative care, et cetera. What's been your perspective on collaborating across specialties, Wes? How does that play a role in your day-to-day practice?
I think this is extremely important, especially with this disease state. Nobody should be working in a silo. Multidisciplinary care is really key to offering the best for these patients. So that's open lines of communication between surgeon, medical oncologist, radiation oncologist. I talk to you very frequently about all these patients. We share clinic together, so we can just talk about them directly. GU Tumor Board is a space that we all use to be able to share and get a lot of other opinions, and especially across other types of specialties outside of oncology, people who are going to help us manage a lot of these adverse events, like our GI specialists, pulmonology, derm, making sure that we have very open lines of communication between everybody. Monty, do you have anything specific to add?
No, that was really terrific. I do think that, we're blessed at City of Hope to just have, so many important resources. I will find, and this is kind of a growing trend in oncology care, that I like to get palliative care involved really early. There was this misnomer that palliative care was something that we might involve at the very sort of last stage of oncology care, but there's increasing data, first in lung cancer and now in multiple diseases, really suggesting that it helps to get palliative care involved early in the continuum of disease, and actually in this context of several randomized studies improve overall survival. Not only that, I just find that it's really helpful to have somebody on my team who's there for the patient in terms of managing day-to-day pain management issues, nausea, vomiting, all the symptoms that arise. The body of literature in palliative care is growing, and I do think the tools at their disposal are growing too. Now, so today, Wes, I think we've covered a lot of really terrific concepts and topics. There have been so many exciting bits of clinical trial data in the non-clear cell RCC landscape. I do think that there are some sizable single-arm studies, such as Keynote B61, as we've discussed, for lenvatinib and pembrolizumab, very compelling data there. I do think that there's good randomized data for agents like cabozantinib, but I do think that the key is that we've got a whole host of randomized studies at our disposal that we really need support in enrolling to. And I will say that there are specific subtypes where maybe they won't ever be candidates for randomized trials, things like chromophobe disease, where maybe we can lean on some of the existing data sets, like the ones we have for lenvatinib and pembrolizumab, and say, okay, here's an avenue through which we can treat patients currently. Ultimately, it's awesome to have team members like you, Wes, who I can lean on for further oncology care and management. And I do really look forward to working with you on many patients down the line through the oncology continuum. Anything else to add, Wes?
Yeah, I think just for the general audience to know that it's important to involve your surgeon early on in the care of these patients. Surgery is not excluded as an option for patients with metastatic RCC, whether clear cell or non-clear cell. But talk to them early, because even if surgery is not delivered up front, it might be a component later on. They'll already know the patient at that time period. They can follow along with their treatment and see how they're doing, but definitely involve them in the discussion and the care of these kinds of patients. It should probably be done at places with experience, so more specialized centers or academic places that have experience in cytoreductive nephrectomy, especially around systemic therapies, but it's important to get them involved too.
Great point, Wes. Great points. And thanks so much for joining us today.
It's my pleasure to be here.
And thank you to our learners. Please remember to take the post-test and fill out the CME evaluation. And for additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com. Thanks so much.